Către pacient. Care sunt dovezile aplicațiilor clinice despre percepția durerii și rezultatele recuperării? Aceasta este următoarea noastră lucrare și va fi susținută de domnul Alexandros Sideris, fizioterapeut din Grecia, formator clinic OMT, specialist certificat în acupunctură.
Dear colleagues, dear physiotherapists, thank you very much for the invitation from the Order of Romanian Physiotherapists to make a presentation on your annual congress. My name is Alexandros Sideris. I'm a physiotherapist. I am from Athens, Greece, and I have a master's degree in applied physiology. I am a manual therapy and musculoskeletal physiotherapy clinical instructor. And I am also a clinical instructor of biomedical acupuncture. And what I will try to say today to you is about the very well-known subject around the world these days. It is the patient-oriented neuroscience education and its clinical applications concerning pain perception and rehabilitation outcomes. This has been actually the thesis of my master's degree. It is a review of the literature. It is a review that I wish it would have a higher level of quality in the inquiry procedure, but I think you will find it interesting enough for you. Pain science is one of my subjects of interest, so let's see if it does interest you. So, as an introduction to the subject, we know that in recent years there is quite a common interest in the researches of pain and behavior to try and find a correlation between the health status literacy and the symptoms intensity, mostly pain, meaning that what they have been trying to see is that how much information a patient has about what is happening to his health if it affects how much pain he feels, which might seem quite interesting and it might seem very close to the boundaries of physiotherapy and cognitive science and psychology. Chronic pain, or as many decide to call it, long-term pain, is one of the most widespread health issues of our time, and it has a very serious economic and social consequence to all societies, mostly to what we call Western societies, European societies definitely. And what has happened in these last 20 years of research is that a thing called pain neuroscience education, we will call it PNE in this presentation. For these patients, it has shown some promising results and some really good perspectives in managing chronic pain. So this narrative review that I'm going to be presenting to you is investigating these results on pain perception and on functionality in patients with this long-term persistent or long-term chronic pain. A few words about what is this pain neuroscience education. In the last 2 decades, the therapeutic option of educating the patient has been practiced as well as investigated for its effect on pain perception. Many very well-known researchers have shown us this. Louvre has been one of the most important ones. And it is the procedure of educating patients on aspects of neurobiology and neurophysiology, pain mechanisms, in an effort to make those patients understandable and easier to conceive what we talk about when we talk about pain science. But pain neuroscience education is not just that. It also includes the addressing of matters like the tissue healing processes, the tissue biomechanics, the cognitive and the behavioral adaptations that patients might develop through pain experiences. And all this should be given in simple terms for people who are non-specialists to fully understand it. So we have to be very careful in what we say to people who do not have a scientific background and they do not have a pain science background. This is the whole idea of patient educating them about pain. Now, one of the pioneers of this idea of this world is the late Louis Gifford. Louis Gifford was the person who started talking to physiotherapists as well as other health professionals, especially medical doctors and psychologists, about pain itself and not the area of the body that has the pain. He started talking to International Association for the Study of Pain seminars back in 1998, 1999, about the actual pain and not the pain of the shoulder, for example. And Louis Gifford has been asking the famous 4 questions. He said that people who are in pain want to know 4 things. First of all, they want to know what's wrong with their problem. Why am I in pain, says the patient. The second thing is, how long is this going to take to get better? The third question, very important, is that, is there anything I can do to help? What is the patient doing in this situation? And 4, and mostly important, is there anything that you, therapist, what you can do about me? And Louis Gifford's legacy over the years led many very important pain scientists, most of them physiotherapists, colleagues like us, have made a tremendous leap, a tremendous movement into research of pain science and pain rehabilitation. And nowadays, we are in a position like this very important article in British Journal of Sports Medicine, like the one that it's by Jeremy Lewis and Peter O'Sullivan, 2 very important, very well-known professors of pain science, saying that, is it time to reframe how we care about people with non-traumatic musculoskeletal pain? And mainly the message that we give through pain education to patients is that they should not be afraid of the pain, and they should try to be more sensible and more correct to the way they approach their problem. And especially us, clinicians, we should try and be more de-threatening to these patients and try to explain to them what is wrong with their body and why they should change the way they are dealing with their pain. So, getting back to the question, what is pain neuroscience education? I would say as its characteristics to be that it should be mostly personalized to each patient, and it should be connected to its personal pain experience. Pain education should be for a specific patient and not in general for someone, for example, who has chronic pain in the neck. It also should preconditions commitment. It should precondition target setting by the patient. So the patient has to be involved in this area, in this idea. It describes the relation between the nociceptive activity and the pain experience. Nociception does not equal pain, and this is a very important message also. It points out the significance of the actual environment as well as the frame of each patient's story on how his pain has been developed. Again, I'm saying that it is a personal thing. It explains the importance of pain being a protective system of the body and nothing else. It's just an alarm clock, a very effective alarm clock of the body. And it describes the actual plasticity, the changeability of the nervous system and its adaptability as the system learns from the previous experiences. So you understand the complexity and again the simplicity, the clear message that pain education should give to these patients. So what is pain neuroscience education? More or less, it is treating patients with pain through the biopsychosocial model. Treating people with patients treating patients with pain through considering them as a whole, as a person, and not as a pathology, a problem. So getting back to the study that I'm going to be showing to you, the purpose of this study was to investigate if this pain education for patients is an effective add-on to a rehabilitation program that targets to reduce pain and to improve function to all these patients who have chronic long-term pain. Now, my methodology was a normal methodology for a narrative review. I chose PubMed and Pedro as my search databases, and in order to be able to produce information that it is reliable, I chose only randomized controlled trials in the last 10 years. And I checked keywords like pain neuroscience education, or PNE, the word explain pain, which is the most well-known word for explaining the patient, the whole idea, the word pain education, and also the word cognitive functional therapy, or CFT, which is one of the most well-known methods of educating the patient about its problems. My inclusion criteria would have to be, all the research should be an RCT, a randomized controlled trial, only chronic pain patients, pain education interventions had to be trialed, the article should be in English, and it should be in the last 10 years, from 2010 and afterwards. Exclusion criteria would involve people who are pregnant, people who recover from injury, any kind of trauma, or any kind of surgical procedure, which of course would not make these patients liable to this review. Drug intakes also would be excluded because they would affect pain perception or any other serious or not serious pathology. Through all these retrieval of articles with the words as you said, starting from an amount of 2,424 articles, as I imposed the inclusion and exclusion criteria, I finally had 18 articles, 18. And what were the general results? The results would be that 6 of the 18 articles concluded that pain education has reduced the patient's pain experience, while the bigger amount of them, 12 of them, said that as a sole, as an only intervention, it would not do much of a difference. But on the other hand, 15 of 18 RCDs resulted that pain education has increased their functional outcomes and reduced the functional deficits of this long-term pain-related dysfunction, while 3 of them showed no much difference. And what will we discuss about this? The results are what we expected in the latest years. And research is this exactly what it is saying, that pain neuroscience education for patients with long-term persistent or chronic pain is not effective for pain reduction, but it is quite effective in improving disability and functional outcomes. So it is a valuable tool. Pain education should not be considered as a standalone treatment, but it is a valuable tool in a multi-centered approach for patients who have long-lasting pain. And this is something that a very well-known researcher, Joe Nitz, says that pain neuroscience education is not a standalone treatment. It's just one more effective and good tool that we have in order to help our patients, our long-term pain patients. Limitations of the study, of course, is that it is not a systematic review, and I stated this from the beginning, but and also the sample is of an adequate size, but very heterogeneous methods. As you see, the methods of comparing with pain education are quite many and different. My strong points on this review would be that they are only RCTs, and as you can see, the outcome measures are very well-known tools, with proven efficacy and very widely accepted by other researchers. So we're pretty sure that it is a valuable, at least clinical result, not in research terms, but in clinical terms. Okay? So as a conclusion, I would say that more research is needed, definitely, better study designs, and we should form a consensus on the topic of pain education, and we should stop arguing about it. There's a lot of argue on whether it is a good tool or not a good tool. I'm in favor of pain education. I tend to teach this, but I think we should research more and in a better way, in a better manner. And these are my references. And